Welcome to Pediatric Neurologic Conditions. We're going to be going over cerebral palsy, neural tube defects, and hydrocephalus. So, starting with cerebral palsy, overview. Cerebral palsy is a group of disorders affecting movement, balance, and posture. It's the most common motor disability in children. It's caused by abnormal brain development or brain injury affecting muscle control, non-progressive brain injury, but sometimes may improve or worsen depending on the area affected. It involves spasticity or dyskinesia, those involuntary movements. Injury can occur prenatally, during birth, or postnatally. Damage is irreversible. So when we look at prenatal causes, it can be genetic factors, it could be Rh or ABO incompatibility, maternal infections, like if mom ends up with um, rubella or cytomegalovirus or toxoplasmosis, those can cause it. We can have intrauterine events where we have ischemia from like maybe pregnancy-induced hypertension or trauma. We can have congenital brain abnormalities. And then also, if we have prolonged or difficult labor, which results in anoxia of the baby, we can have it. Perinatal causes can be metabolic conditions, intracranial hemorrhage, low birth weight, prematurity, and postnatal causes, like if the baby gets meningitis or another really bad infection, trauma, stroke, or exposure to toxins. So, associated neuromuscular disability. Neuromuscular issues in cerebral palsy occur due to damage to the specific areas. Types of CP depend on the location of the brain and the insult. Different forms of CP can present with varying movement and muscle control patterns. This chart represents the characteristics associated with those different types of cerebral palsy. Nursing care. So, your overarching goal is to preserve muscle tone and prevent contractures. Assessment of children with this, we want to monitor at-risk infants for early signs like irritability, feeding difficulty, delayed developmental milestones, poor motor development, abnormal posturing, persistent primitive reflexes. So the majority of your primitive reflexes, like your Moro, your palmar grasp, and your rooting, should all be gone by 6 months. And then your plantar grasp is about 6 to 12 months. So in these kids, we're going to see them beyond that 6 month period. We might have poor muscle tone and an ataxic gait. Evaluation of the environment. School nurses participate in education planning. We need to assess the need for physical and learning adaptations, facilitate use of assistive devices. These kids are going to have walkers, wheelchairs, communication boards, and computer aids. Interventions to support mobility. We want to assess and monitor mobility and therapy response. Are our joints mobile and free of contractures? Is mobility and self-care maintaining or improving? Can caregivers demonstrate therapy techniques? Has the school been up to date about our care changes if they develop? We want to reinforce physical and occupational therapy routines. We want to encourage parent participation in daily exercises. We want to determine the need for specialized equipment for reading, writing, eating, and mobility. We want to collaborate with physical therapy and occupational therapy so that we don't get those muscular contractions and that we maintain muscle mobility as much as we can. We want to monitor for chronic pain, especially if we do any surgeries or interventions. Encephaly, this is the most severe neural tube defect. It's a congenital malformation in which both cerebral hemispheres are absent. Many of these infants are born stillborn. If born alive, lifespan is limited to hours or weeks. Clinical characteristics. If the brainstem is present, infant may temporarily maintain temperature regulation, cardiac function, and respiratory function, but death is usually from respiratory failure. There's no curative treatment. This is just providing comfort measures. Resuscitation is not typically indicated, and this is a lot of family support, um, knowing that this condition is incompatible with life. Families may be faced with ethical and emotional decisions about withdrawing the care, considering organ donation. So, lots of emotional support, counseling, palliative care referral, neonatal hospice involvement is really the best approach with this. Now, spina bifida, this is another neural tube defect. This congenital neural tube defects involving incomplete closure of the vertebra and the neural tube, classified into spina bifida occulta and spina bifida cystica. Spina bifida occulta usually occurs at L5 through S1. The vertebral fails to fuse, but no sensory or motor deficits is noted in most cases. We might have a little dimple, a little tuft of hair, maybe a hemangioma or a lipoma in the lower lumbosacral area. It's often found incidentally on imaging. Spina bifida cystica, this is an incomplete closure of the vertebral column with cyst formation. And then we can have a myelomeningocele, which is a sac that contains spinal fluid and meninges. We can have a myelomeningocele that's more severe, that the sac contains spinal fluid, meninges, nerve roots, and spinal cord. That leads to greater sensory and motor impairment. Your etiology and incidence, the exact cause is unknown. We think possible genetic predisposition. Maternal folic acid deficiency is strongly linked to neural tube defects, which is why we recommend a daily folic acid for all women of childbearing age. Clinical manifestations depends on what level is involved. So if T12 is involved, we're going to have flaccid legs, decreased sensation, bowel and bladder incontinence. If we have L1 to L3, hip flexion issues, and filial feet. T2 to T4, hip abduction is affected. L3 to S2, hip abduction, hip extension, knee flexation limitations. S3 and below, usually no motor impairment. Sacral root involvements will have plantar flexation affected and may also have learning or cognitive impairments, dysphagia, and poor growth or fine motor skills. And this is just kind of a lovely little image that goes through the different ones of these. So obviously, number one is normal appearance. When we talk about the spina bifida occulta, we have a small gap in the spine, but there's no visible opening or sac. So your spinal cord and your nerves are typically normal. It's usually undetected into later childhood or adulthood. And as I said before, it's usually an incidental fine because it does not cause disability. Now, when we talk about the meningocele, that is a sac of fluid that protrudes through the spinal opening. The sac contains meninges and spinal fluids, but not any of the spinal cord. So since the cord's not involved, there's little or no nerve damage, and we might have minor disability. If we have the myelomeningocele, that's number D on here, that's the most severe. So with this, the sac contains spinal fluid, meninges, the spinal cord, and nerves. The nerves are damaged, so this is going to cause moderate to severe disabilities where we can have paresthesias, paralysis, And think about the paralysis. If it's involving the bowel and bladder, we're going to have issues with, urine and stool passing. All right, a little bit more about the pathophysiology. So, this is just for the myelomeningeal seal. The rate is declining in the United States, and we kind of link that to our folic acid supplementation. We have a lot of foods that are folic acid enriched, and we're just having better prenatal screenings. But if it's going to develop, it usually develops during the fourth week of gestation, where the neural tube fails to close properly. Severity again depends on the level of the spinal cord involvement, as well as the size of the defect. 90% of lesions occur at or below L2, lumbar 2. Associated musculoskeletal findings. These kids can also end up with club foot, scoliosis, and hip contractures and dislocations. Associated neurologic complications. They can have Arnold-Chiari malformations. Hydrocephalus occurs in about 80% of these infants. And then also we have a mortality risk of 10 to 15%. And remember, these are the myelomeningeal seals, so those are the ones that are the most significant. Kids with spina bifida are at an increased risk for latex allergy, and this is due to frequent exposure during catheterizations, shunt placements, and all the repeated surgeries they get. So about 73% of kids with spina bifida end up with a latex allergy. It can be really mild to itching and rash to very severe anaphylaxis. So any child with spina bifida, nursing consideration, we want to start latex precautions early at birth. We want to check all medical supplies for latex content. We want to use latex-free alternatives consistently. And then don't forget your dietary and environmental latex precautions, right? When we're talking about dietary, we're thinking about, those tropical fruits and bananas, kiwis, balloons. If it's a latex balloon, that can be a problem. Dog toys have latex. So it's educating the parents about that as well. Spina bifida care. There's a lot. So when we're talking about pre-operative nursing, if we have a child with a myelomeningeal seal, it's really important to position the infant prone because we want to keep that sac protected. We have to keep that sac free from stool and urine. We want to make sure that the sac stays moist. So we do a sterile, moist saline dressing. Legs in a natural position. We want to measure head circumference at least once every 8 hours, just checking for that potential increased intracranial pressure. We want to assess their neurologic function. We want to monitor for infections. If they put a catheter in, we need to do our routine catheter care. If we're doing just in and out catheters, we want to make sure that we're doing that at least every 6 hours and performing that sterile. Because remember, if we have the myelomeningeal seal, that's going to create a neurogenic bladder where they can't pee themselves. We need to self-cath for them. And then, of course, remember, this is a little baby, so we still need to be doing our atraumatic holistic care where we're promoting parent-infant bonding. Post-operatively, we continue the prone position. We want to perform those same neurological assessments, those same infection assessments. We're adding on inspection of the incision and the drain for infection. And we also continue to monitor that head circumference. Long-term care, we need to teach them intermittent catheterization. Just because we have put that spinal cord back inside, it doesn't mean that they're now going to have use of it. So they're going to have to self-cath, for their lifetime. So we need to teach families how to do intermittent catheterization. And eventually the older child will be able to catheterize themselves. We also need to establish bowel management programs because they're going to have issues with evacuating their bowels. So we want to do high fiber diets, adequate fluids, scheduled eliminations, and suppositories and other interventions as needed. We got to assess skin integrity, assist with range of motion exercises, ambulations, bracing. We're going to be collaborating with a big multidisciplinary team here. There's going to be nutrition on board, physical therapy, occupational therapy, urology, orthopedics, neurology, all the big ones, because of a little bit of them is needed for each management of this kiddo. We want to promote independence. We want to support the child in achieving maximal functionability. We also need the families to understand that we need realistic goals. And then I got a little extra note here on the neurogenic bladder, right? So because we have that blockage point, the nerve signals between the bladder and the brain are going to be impaired. So they might have some urinary dribbling, they might have loss of bladder sensation, they might have incontinence. We need to prevent kidney damage. So for that, we're going to be doing medications, catheterizations, antibiotics, or even surgeries, because they're not going to feel that that bladder is getting full. So if the parents aren't doing routine catheterizations, we can have that urinary stasis that can create issues with risk for infections. And we know that reoccurring infections, depending on how it goes, could lead to kidney damage. So possible complications, urinary retention, leakage, UTIs, kidney damage. Now our hydrocephalus. So hydrocephalus is caused by an imbalance between our cerebral spinal fluid production and absorption. So excess cerebral spinal fluid accumulates, the ventricles dilate, and then the brain becomes compressed. If the cranial sutures are open, we get an enlarged head. If the sutures are fused, we get signs of increased intracranial pressure, which I'll discuss more on the next slide. So the etiology, it may be congenital, it could be acquired, it could be unknown. Infants most often have congenital. Congenital causes could be an Arnold-Chiari malformation, congenital tumors, some stenosis, maybe a cyst. Premature infants often related to neonatal meningitis or subarachnoid hemorrhage. Frequent association with the myelomeningioceles. These kids get hydrocephalus. Older children, it's usually due to meningitis, tumors, or some type of hemorrhage. Incidence, um, obstructive hydrocephalus is more common in children. Communicating hydrocephalus is more common in our premature infants after a hemorrhage. So our manifestations, hydrocephalus manifestations in an infant, early signs are going to be rapid head growth because of we have those fontanelles that are open. So we're going to start to have that bulging of them. It's going to get full, and therefore we're going to see their head kind of swell up. And with that, we're going to get irritability, poor feeding, and really distended, prominent scalp veins. Later signs in kids, if that's missed, we're going to see setting sun sign, which is the sclera is visible above the iris, and that's because the that's like that Sampaka lie, where the eye is starting to bulge out. So where we would normally just have the iris, what we're looking at, you then have the white sclera around it because that eye is bulging. We can have fontanelle bossing, which is an enlarged forehead. And again, the fluid is starting to like shift. Vomiting, feeding, difficulty swallowing. We'll start to have an increased blood pressure and a decreased heart rate. We'll have altered respiratory patterns. Shrill, high-pitched cry is one of those like key things. And then sluggish and unequal pupils. Again, late sign, and anytime we have sluggish or unequal pupils, that is a medical emergency. Neurology needs to be contacted. In a child, early signs, morning frontal headaches, really common, that they wake up and they have like this pressure in the front of their head. And a lot of times it's relieved when they sit up, and that kind of helps to facilitate that drainage. Sometimes they vomit and they feel a little bit better. Nausea and vomiting could be projectile. We might start to have visual issues. They might have strabismus, they might have diplopia. They could be a little restless, they could be a little ataxic, a lot of irritability. Again, sluggish or unequal pupils, confusion and lethargy. Um, One thing, when it's building slowly, we might start to see like a decline in school performance and some behavioral or personality changes. Late signs in kids are going to be seizures, changes in that high blood pressure, low heart rate, irregular respirations, development of blindness, or decerebrate posturing and rigidity. And at that point, I mean, when you're having those irregular respirations, blindness, and posturing, you're getting so much pressure that we're starting to push on our brainstem. So what do we do for these kiddos? VP shunt, right? A ventroperitoneal shunt, where the shunt enters the ventricle and runs under the skin to the peritoneal cavity. It may start as external. That's what we do at Children's, where it's external. And then eventually we do a secondary surgery where we put it under all the way. Postoperative positioning is really important. The child needs to be placed on their non-operative side, which makes sense, right? We put a shunt in their brain, so the last thing that we would want them doing is laying on the shunted side and kinking it. We need to monitor for head circumference, just so that we know that it's draining. We want to monitor the abdominal girth and bowel function because it's draining into that. So if we start to have distal shunt complications, like peritonitis or an accumulation of that cerebral spinal fluid, we're going to start to see that the gut will start to swell. Some shunt complications, infection occurs in about 10% of children within the first 6 months. Shunt malformations are very common in the first 2 years. We want to monitor closely for fever, neurologic changes, vomiting, and irritability, because that would be signs of infection or shunt dysfunction. Family education is important. And then we also need to educate the family that, we can fix all of this, but as that child grows, that shunt doesn't grow. So very frequently, these kids need frequent revisions. So the parents will start to see signs of that increased intracranial pressure happening again. Very often, the physicians caring for these kids will do routine screenings to make sure that we catch it beforehand, but a lot of times they'll end up in the emergency room with complaints of like headaches or behavioral changes or, vision issues, and, it's just their shunt needs to be revised. So therapeutic management, the goal is to prevent further cerebral spinal fluid accumulation and reduce disability and death. The treatment is to bypass the obstruction and drain the cerebral spinal fluid to a site for reabsorption, which is usually the peritoneal cavity. So the VP shunt starts in the brain, goes down to the peritoneal cavity. That's the most common one that we do. Post-operative VP shunt surgical nurse assessment. So again, we want to place the child on the non-operative side. We want to make sure that we're maintaining head and neck alignment. We want to measure the head circumference daily and monitor for changes in size. We want to monitor the abdominal girth daily. So we notice if it changes inside. Our neurological assessment, we want to watch for irritability, nausea, vomiting. If it's an infant, bulging fontanelles? If it's a child, are we having headaches? Are we having worsening of neurological status? Are we having changes of level of consciousness? Are we having unequal or sluggish pupils? Are we having posturing or seizuring? Return or progression of hydrocephalus symptoms will be an indication that the shunt has an obstruction. Shunt malformation is common, as I said, in the first 2 years of life. And then again, as the child grows, we end up having more. We need to monitor for signs of shunt infection, which could be fever. Fever is going to be a critical early sign. We could have signs of meningitis, so stiff neck, irritability, lethargy. We could have redness, swelling, or drainage along the shunt track or incision site. We can have signs of sepsis like tachycardia or poor perfusion, and changes in the neurologic status. If an infection is suspected, we need to prepare for IV or intrathecal antibiotics and or temporary shunt removal. Again, monitor that abdomen. We want to measure the abdomen girth routinely. We want to assess for abdominal distension. We want to auscultate for bowel sounds. We want to monitor for vomiting. And we want to report any signs of peritonitis, which would be fever, guarding, or pain in the abdominal cavity. Device and equipment, we want to avoid magnetic devices near programmable shunts. So if your child has a programmable shunt, tablets, iPad, magnetic toys all need to be kept away from that valve. So you need to be able to know where the valve is and where they need to keep it away from. Long-term monitoring, again, recognize that shunt revisions are very common as children goes. Early ensuring that families understand will help to seek treatment accordingly. So if we have signs of malfunctioning, signs of infection, and when to seek immediate medical care are all important with family education. And that is the end of this lecture. Thank you.